Welcome everyone to the Semel Institute Child Psychiatry Grand Rounds. My name is Cheryl Kataoka, the Associate Program Director for the Child Fellowship. Throughout this presentation, please feel free to type in your questions in the Q&A, and we will answer them at the end of this talk. It is my distinct honor to introduce our speaker this morning, Dr. Edward Castelo. Dr. Castelo began his career knowing he was interested in the mental health of under-resourced children as far back as his undergraduate years at Stanford University, where he majored in human biology with a concentration in behavioral and social development of minority children. He then worked as a behavioral therapist with children who have autism and on ADHD research projects with the esteemed doctors McCracken and McGuff, which resulted in 2 publications. He then completed medical school at Temple University in Philadelphia and psychiatry residency at Harbor UCLA. We were so thrilled to match with Dr. Castelo in our Child Fellowship program. He has provided outstanding leadership as one of our 2 program chief fellows. Dr. Castelo has also had a long-standing interest in school mental health, and I have enjoyed seeing him contribute to our Kaplan and Sadok chapter on school consultation and hearing about how engaging his talk was on wellness and self-care that he gave to a group of high school students interested in being mental health peer navigators at LA Unified. As one of his mentors this year, I have been so proud of all that he has accomplished and excited for his next chapter as a faculty member at Harbor UCLA, where he will be attending in the child psychiatry emergency room and medical director of the pediatric CL service. I'm hoping he will still be able to find time eventually to use his consultation skills in schools. Here to present on school mental health and the impact of COVID-19 is Dr. Edward Castelo.
Thank you so much, Dr. Carioca, for those kind words. And I want to welcome everyone to the Grand Rounds today. I'm humbled and honored to be here. I'm going to start my screen share here. Oh, hold on a second. Sorry. There we go. All right. So today I'm here to talk about school mental health, give an overview and a background, and talk about the impact of COVID-19 on school mental health. I just want to remind everyone, as Dr. Carioca mentioned, please use the Q&A function throughout the talk for any questions, and we'll have about 5 or 10 minutes, hopefully at the end, to answer those questions. I'll also be joined, as I'll mention later, by Griffin Espinoza from LAUSD, who will also be available to answer questions about school mental health and how it looks in the school district. I don't have any disclosures to report. And before I begin, I want to continue the tradition that was started by my esteemed colleagues, Dr. Zach Schwab and Dr. Manal Khan, of paying tribute to one of our mentors and colleagues, Dr. Mark Dantonio, who is a dear friend to many of us and just a great teacher and had such a large impact on our training program. So I'll just take a few moments to reflect on his legacy. Thank you. So here are the learning objectives for today. They include identifying a couple of evidence-based interventions which are available in the school setting, naming a couple of areas in which children have been impacted by the COVID-19 pandemic and their subsequent school closures, and then also hopefully be able to describe ways in which school mental health provision and access has changed as a result of the pandemic. In order to accomplish these learning objectives, my goal is to start with by taking everyone on a journey through the evolution of school mental health systems from its genesis in the 19th and 20th centuries to the modern day school mental health systems today. I'll then focus on a specific model of mental health service delivery, which is the School-Based Health Center, and discuss how the pandemic has changed the way in which students access and receive mental health services, as well as non-academic supports from the school. I'll briefly touch on telehealth services and how it's changed because of the pandemic for mental health service provision, and then touch also on some of the future directions and considerations for all of us as mental health practitioners who treat children and adolescents in community settings. Finally, as I mentioned, I'll be joined by Kim Griffin Espinoza from the LA Unified School District, who provide some insights into how mental health service delivery has changed and will continue to change in the school-based health centers from a district level perspective. So why am I giving this talk today? I want to share a little bit about why this is an important topic to me. So education and using and leveraging schools and school structures as tools to serve children in less resourced communities has been a consistent value of my life. I owe this to my grandmother and my Tito Ed, who I'm named after, who were fierce proponents of advancing the attainment of youth in my mother's hometown of Tacloban, a small rural town on the Big Island of Luzon in the Philippines. The town is about 50,000, and measurements in 2006 reported that about 50% of the population in the town were underneath the poverty line. My grandma and my uncle believed that supporting children via education or resiliency skills would help them or bolster their ability to bring themselves and their families out of poverty and provide them opportunity in a very quickly globalizing society. So what did my grandma do? She founded a high school about 75 years ago, which I've actually had the honor and privilege of working in after college, after my undergraduate degree, and even before then, when I was a junior high schooler myself. This is a photo from about 1 week prior to the lockdown, actually, in March of 2020, with me and my wife, who's a child psychologist by training. And we spoke to the students during this time about ways to approach the transition of moving away from home after high school, and how to manage some of the challenging emotions that surround this transition. As Dr. Carioga mentioned, my goal is, though I will be working in an ER, my goal is to continue to collaborate and partner with schools to help support the emotional well-being of students throughout Los Angeles and the global community at large. So that's a little bit about why this is important to me. I want to share some numbers as to why I think school mental health is an important topic for all of us. So CDC reported in 2013 that 13 to 20% of the US in a year will experience a mental health disorder. Our very own Dr. Carioga in 2002 and her colleagues found that about 80% of children and adolescents aged 6 to 17 years old who required mental health treatment services did not receive them. At the greatest risk for having unmet need were those students that were uninsured or identified as Latinx. A report in the early 2000s also revealed that about 80% of children with mental health disorders receive their services through the school system. This remains true today, as a recent meta-analysis revealed that the most common site of mental health service delivery is actually within the school setting. So I hope that in this talk, I can impress upon you the importance of school mental health and how we as clinicians and providers can be advocates to help improve the lives of the youth that we treat. So I want to start a little bit with a historical perspective on mental health delivery in school settings. We have to go back to the progressive era of the late 19th and early 20th century, when societal changes were reflected in a changing view of the education system. During that period, there were some significant changes in what schools were asked to provide, as there were laws that ended child labor, changes in urbanization, increase or alterations in the social order, and an increase in immigration. And also during this period, there were some significant changes in the development and the fields of psychology, social work, and education. One example of some of these changes is reflected in the number of school days that children were attending school, and the number of students enrolled from the beginning of this era to the end. So as you can see here, the number of school days that students attended rose by about 40 days. And the number of students that were enrolled in schools increased by about 14 million students nationwide. These are some of the individuals that were key vanguards at the forefront of changing the mental health system and how it was viewed within the context of education. On the left is Dr. Leitner Whitmer, who created the first psychological clinic at the University of Pennsylvania in order to study children and with behavior and learning issues in Philadelphia area schools. An interesting sort of side note is that he was also credited with coining the term clinical psychology. In the middle is Granville Stanley Hall, who was the first president of the American Psychological Association. He created the child study teams, which promoted child-centered as opposed to teacher-centered learning, which was common prior to the progressive era. The study teams that he created initially focused on normal development of children, and then later came to incorporate abnormal development in its purview. And finally, on the right is William Henry Maxwell, who was a superintendent of the New York City public school systems during the progressive era, who helped to usher in the idea of special education or special classes for children who were intellectually disabled. And he was quoted as saying he wanted to develop each child fit or unfit to his highest education. The work of these three men and others of their time collectively brought about some ideas of collaborating with schools and external agencies in order to improve mental health delivery to young children and in the education system. Coincident with these changing ideologies and development of new concepts, there were also changes in the role of various healthcare players within the school system. In October of 1902, Lena LaVanche Rogers became the first school nurse in the United States, when she was then asked to be a school nurse in the New York City public school system. On the right is Arnold Giselle, who was the first school psychologist in the United States when he was appointed in 1915 as a school psychologist for all of the schools in the state of Connecticut. In the 1920s, the first school social workers were hired to become school employees. They were termed visiting teachers, and they helped link immigrant and under-resourced families with school systems and the services they provided. And around the same time in 1924, Carl Menninger founded the American Orthopsychiatric Association, along with a collection of other psychiatrists, psychologists, social workers, whose main goal was to collaborate in an interdisciplinary fashion to help improve mental health in community settings. The American Orthopsychiatric Association still exists today, actually. After some of these initial shifts within the specific fields in psychology, social work, and education, and changing in school roles, there was a new era of public focus on some of the deficiencies of the mental health care system. And this led to changes in policy on a federal level. In the era of social activism and civil rights, in 1963, Congress passed the Community Mental Health Centers Act, which called for construction of various mental health centers. And within this, schools were seen as an ideal setting for the delivery of mental health care to children and adolescents. There was also a shift at that time from a more individualized model of assessing and treating children to including also a consultation-based model where clinicians also provided universal preventive interventions. Another important date is in 1992 when Congress passed legislation to establish the Substance Abuse and Mental Health Services Administration. As part of its aim or goal, the funds were allocated to develop systems of care for children and adolescents through the Comprehensive Mental Health Services for Children and Their Families program. This program is the precursor to what we would consider now as wraparound services, and advocates in 1992 we're calling at that for embedding mental health clinicians within the school system. So those are some of the changes in roles and some of the historical changes that led to the evolution of the modern day schools mental health system. So what does comprise a comprehensive mental health school system today? This figure from a 2019 report written by Partnership of school mental health stakeholders and leaders, including SAMHSA, the School-Based Health Alliance, which is a nonprofit agency and organization who looks at school-based health centers and school mental health. The U.S. Department of Health and Human Services and faculty from the National Center for School Mental Health in Maryland. This figure shows some of the important features to what's necessary for a comprehensive school mental health system. So important core features include having well-trained educators and specialized instructional support personnel. It involves partnership, collaboration between families, schools, the community, and also assessing needs and mapping resources, which is important to help target some of the evidence-based interventions, some of the screening practices. And all of this includes gathering data and requires financial backing and support. And so one model of delivery, school mental health delivery that I'll talk about is the School-Based Health Center. But before I talk about that, I want to touch on feature 4 here, which is the multi-tiered system of support, and talk about how the different evidence-based practices which are delivered within this system. Now, the multi-tiered system of support framework was born out of the integration of 2 different other frameworks that were coded within the Individuals with Disabilities Education Act. Those frameworks were the RTI, or Response to Intervention, and the PBIS, or Positive Behavior Intervention and Support frameworks. This is just one model that's used within the education system to consider integrating various services available within a school campus. Excuse me. It's used by educators and teachers and administrators to think about the instructional services that are required for some of our students, and then also by clinicians and administrators and teachers to think about the social, emotional, and behavioral development of students within the school. So what's in each of these tiers? So tier 1 encompasses a whole class or whole school approach, meaning that pretty much all students receive this type of intervention. One example of this is the social emotional learning curriculum, which helps students identify emotions and develop supportive relationships. A lot of the folks we see here in our clinics will likely have received some sort of tier 1 intervention and may have some familiarity with some of the skills that we would discuss in our sessions. So that's why these tiers are why that is the case. In tier 1, there's some periodic monitoring and to help track students who may be at risk for issues and may require referral to a tier 2 intervention. Tier 2 interventions involve more sort of focused interventions for smaller groups, and they use different instructional methods than what might be provided in tier 1, as opposed to, say, the universal or all school or whole classroom approach. It's like, as I mentioned, delivery typically in a smaller group setting, and students that receive these interventions are tracked more frequently and monitored more frequently and for a longer time than those students in tier 1. And that's because depending on the progress of a student, they may be referred back down to a tier 1 intervention or may be referred to a more intensive intervention in tier 3. Tier 3 interventions are what are provided mostly by mental health clinicians and includes more individualized or group treatments. I'll talk about 1 or 2 of the tier 3 interventions, but most of what we provide as individual clinicians would typically fall under tier 3 interventions. So let me give you a few examples of some of the interventions that are available within the school within each of these tiers. These are just three of, this is not an exhaustive list by any means, but these are some examples of programs that exist and evidence-based practices that exist within the school settings and are available to school districts. And so these include the Incredible Years, the PASS program, or Promoting Alternative Thinking Strategies, and Positive Action program. Now, the Incredible Years is a program which involves training teachers on positive classroom management. It includes using attention skills, praise and encouragement, incentives for challenging behaviors. It's found to have had various positive effects on pro-social and improving externalizing behaviors when it's been provided in higher doses and to children at high risk for externalizing behaviors. PASS is a program that trains teachers on promoting emotional and social competencies and reducing aggression and behavior issues. It teaches students self-control, feelings identification, how to manage relationships, and helps them learn problem-solving skills. And the program has led to improvements in externalizing behaviors and substantial reductions in self-reported depressive symptoms in a group of students who are in special education. Positive Action is a program which integrates brief classroom lessons, and it's integrated into the social and emotional learning curriculum of schools. And they teach, again, about emotions, behaviors, positive actions, things of that nature. And different studies have found that there are positive effects, including improvement in positive affect, improvement in life satisfaction, and reduction in symptoms of depression and anxiety in students in urban school setting. As I mentioned, those are some of the interventions that are available to the school or provided in a whole school or universal approach. As we move into tier 2 interventions, these are interventions that are typically provided in smaller groups and for students who are at high risk for either behavioral issues or academic challenges. And again, this is not an exhaustive list, but includes programs like the Coping Power or the Strengthening Families program. Coping Power is a group program or a group intervention for parents and students, which emphasizes problem solving, conflict management, coping mechanisms, and social skill development for children who are at risk for substance use disorder or delinquent behaviors. It also involves parent skills training to help manage stress and identify some of the disruptive behaviors that a child may manifest. And students who received this intervention reported less delinquent behavior and substance use and improvements in social competence. Parents also reported improvements in their own parenting skills as a result of having gone through this program. Another similar program is the Strengthening Families program, which is a similar group intervention that focuses on family protective and resiliency skills to help reduce some of the risks related to substance use or other disruptive behaviors. It's been found to help mediate lowering the use of alcohol, initiation of marijuana use, and also lowering rates of methamphetamine use in the past year for students who received this intervention. Finally, tier 3 interventions are those interventions which we would consider to be more of the individualized interventions. One example of this kind of intervention is the interpersonal therapy adolescent skills training manual, manualized treatment, which was developed by Jamie Young out in Pennsylvania at CHOP. It's delivered by clinicians, which most tier 3 interventions would be delivered by, to help decrease depressive symptoms by focusing on some of the developmental and interpersonal needs of adolescents. And Dr. Young found in her research that the program improved depression and anxiety in students who received this intervention as opposed to those that received, say, group counseling. And again, this is a short-term treatment. It's about 8 weeks. So this is just one example of some of the tier 3 interventions that are available in the school setting. So that's a digression into some of the evidence-based practices that are available in this school setting. So now I want to talk a little bit more about a specific model of school mental health delivery, which is the school-based health center. So these clinics or these health centers or clinics, as they were initially termed, actually started in the late 1960s in Dallas and in various communities, such as Dallas and Cambridge in Massachusetts, and were started out of by pediatricians, inspired by the CATCH program or Community Access to Child Health program. So folks like Philip Porter out in Boston and folks from the University of Texas Health Science Center in Dallas opened clinics in elementary schools within their area. Some of these clinics were initially staffed by nurse practitioners and were only open for a couple of days. But as the pediatricians and clinicians saw an increase in need, they quickly shifted to sort of having it open 5 days a week. And some of the goals of these clinics are some of the goals that we have today include increasing awareness of preventative healthcare, improving healthcare decision-making, detecting signs of emotional distress, reducing risk-taking behavior, and providing treatment for acute and chronic conditions, and helping with family planning, for instance. So in 1978, the Robert Wood Johnson Foundation put about $40 million at the time to look at some of the effectiveness and sustainability of these clinics. And as more data were gathered, that showed that these centers had positive outcomes or students that received services through these centers. Then certain states started to establish investment and funds for the establishment of school-based health centers. And this was also buttressed by Medicaid expansion, which helped to increase healthcare coverage for students in under-resourced communities. So as a result of this increase in financial backing and support, there was a rapid expansion of the number of school-based health centers in the country, from 31 in 1985 to recent estimates of about 2,500, almost 2,600 from a recent school-based health census in 2017. And they're available in 48 states, Puerto Rico, and DC. So here's some of the evidence of why school-based health centers are such a wonderful model for delivery of both physical and mental health care. Students who accessed or had access to school-based health centers had an increase in immunization rates by about 15% and utilized preventive services or increased their utilization of preventive services by about 12%. Students who also had access to SBHCs found there was a reduction of about 25% in ED visits for both medical and mental health visits. Economic evaluations of the value of school-based health centers reveal that there's a net financial benefit of about $15,000 to $912,000, large range, I know, when per school-based health center. And there was also a net savings for healthcare payers, things like Medicaid, of about $30 to $900 per visit. This was likely due to maybe avoidance of ER visits and avoiding or delaying teen pregnancy, for instance. And so there are other studies that show that those who access mental health services through the school-based health centers also had improvements academically, such as improvements in their GPA and reduction in rates of school suspension or high school non-completion. Other studies have shown that students who utilized and accessed the SBHCs or mental health care in the SBHC had reduction in risk of depressive episode onset, suicidal ideation, or suicide attempts by about 20%. Students who also accessed SBHCs also reported improvements in feelings of connectedness and improvements in their school experience of school life. So the location of school-based health centers varies depending on the clinic. Traditionally, school-based health centers were on a fixed site on the school campus where mental health providers and primary care providers were co-located. There are school-linked health centers, which the major difference is that the clinic is off-site or next to a near campus or next to the campus. And students will access their care through there, and the primary care providers are available at that site as well. There are mobile school-based health centers, which are either in vans or buses that are parked near or at a school campus, with this where the student would go in, and then the primary care provider or mental health provider would be within that van or bus. And then finally, there are some telehealth exclusive sites, and I'll get to these numbers a little bit, but as we know, in the COVID-19 pandemic, there has been an increase in the number of telehealth exclusive school-based health centers. One of the reasons that this is important and the school-based health center is important is for access. We know that access to high quality healthcare is an important determinant of health outcomes. Census data from the school-based health centers reveal that about 89% of the school-based health centers provide access to vulnerable children in schools with a high percentage of low-income students, and that utilization of school-based health centers is highest among Black students and students with public or no insurance. Moreover, a study looking at utilization of mental health care in the school-based health centers found that students were 21 times more likely to start a mental health or initiate a mental health care visit at a school-based health center as compared to a community clinic. And that's because of familiarity. Many of these clinics are on site. The providers are there, and students see these faces and are more comfortable seeking out care in this space. And so, given these data, I think there's a link between the pandemic school closures and the widening disparity gap of outcomes between minorities, children, and families in higher economic and higher income communities. I want to talk about how COVID has impacted the school-based mental health delivery and school-based health. But first, I want to share a video from 2020. Of students talking about their mental health.
I'd say 6 months ago that I was pretty much a typical teenager.
I had this anxiety and stress of school.
Stress between school.
Oh, sorry. I'm sorry.
I'd say 6 months later.
I had this anxiety and stress of school.
Stress between school and extracurricular activities.
My mental health was better than it had been in a long time.
I was pretty happy most of the time.
I was just waiting to hear back from colleges, very excited. But,
COVID-19 can be characterized as a pandemic.
The coronavirus is a pandemic.
Many schools around the world, as you know, have shut down.
It's going to have a huge impact.
Right now, with the coronavirus and quarantine and everything, I'd say I've kind of retreated to a more isolated version of myself.
I definitely feel a little more frustrated and sad.
You start to worry about your future, and you start to worry about, am I ever going to see my friends again?
I'd say especially in the months right before the virus, I was really branching out at my new school and making connections, but I do feel as if I've fallen back.
Just really not knowing how things are going to turn out and just rethinking your future and your life, and it really took a toll on me.
What's been worrying me the most during the pandemic has been getting sick, or my family members getting sick.
I'm very, concerned about being a carrier of the virus or bringing it home or spreading it between people by going out.
When you're isolated by yourself, you're really just alone with your thoughts.
I've never said this before, but I miss school. I'm worried that it's just going to extend longer and longer, the closure.
I definitely know a lot of people who are struggling with depression and anxiety.
Especially, I think, for transgender people, I've been hearing from my friends, looking at your own body image in a camera or listening to your voice, especially for people that haven't made transitions yet, is very dysphoria producing.
I do have some friends that suffer from some mental health issues, and they do seem a lot more down now because of the virus.
I also have a friend who has some family troubles, and I feel like her stress has been amplified now that with quarantine and stuff like that, not being able to see her also makes it worse because we can't really talk about it, and I can't really comfort her the way I would be able to if we see each other face to face.
So, sorry. So as these children mentioned, the pandemic brought about significant changes in their lives. And there's also data that suggests that it's impacted the family system. A survey of about 1,000 parents and published in Pediatrics in 2020 revealed that about 27% of parents reported their own personal mental health worsened during the lockdown. And these same parents reported about 14%, or 14% of these parents revealed that their children's mental health worsened. And though this study revealed similar rates of reporting or worsening of mental health across various subgroups of race, education, income, communities of color have actually borne the brunt of the negative impacts of the pandemic. So prior to the pandemic, children and families in communities of color were already at risk for traumatic and toxic stress. And some of the determinants of health that played a role in increasing this risk included things like food insecurity, community or family violence, racism, death, loss, housing instability, unemployment. Children in these communities were also impacted by the same issues, either directly or indirectly, for instance, through parental job loss or loss of family members due to COVID illness itself. These stressors and the losses subsequently increase the risk of traumatic experiences, which can lead to poor mental health and academic outcomes, including disruption in educational attainment and loss of learning opportunities. In fact, education researchers believe that the COVID-19 pandemic will only serve to increase the academic achievement gaps between students from low-income families and students from high-income families due to loss of learning opportunities. There are a number of factors of why this might be happening, and factors that impact the education system. As I mentioned, school-based health centers serve as access points for healthcare for many children in disenfranchised communities by providing basic healthcare screening, management of acute and chronic conditions, which again are important for determining health, overall health. But apart from the school-based health centers, schools play a really important part in a child's and family's well-being. They provide access to free or reduced price lunch for those families challenged by food insecurity. It's also a place where physical activity and healthy eating habits are promoted. And also school personnel who are available and clinicians played really important roles in linking unhoused or unsheltered children with needed services or protecting children who may be at risk for suffering from abuse, neglect, and maltreatment. And so the losses due to school closures have subsequently played a large role in impacting mental health of children and youth in under-resourced communities. This is borne out by some of the reports from school-based health clinicians who mentioned that during the pandemic, they saw an increase in students' reports of anxiety, depression, grief, and withdrawal, as the students in that video mentioned. They also reported increases in parents reporting of changes in their children's mood or temperament. There was also an increase in the presentation or the acuity of a client's presentation as a result of delays in treatment. They also revealed that as a report of COVID-19 illness itself or callouts, there was limited staff availability from both the clinic and the school end. And this led to decreases in referrals and care access for students because there wasn't any face-to-face contact or ability for teachers to speak directly with the mental health providers who were there right in front of them on a daily basis prior to the pandemic. And so many clinicians actually proactively reached out to schools or teachers for the referrals. There were also issues accessing patients. I'll talk about the digital divide in a minute, but there were issues with some of the changes in the school's schedule that limited the clinician's ability and the students' ability to access the clinical care that they needed. And then they quickly shifted their mode of service delivery to telehealth. So this is from a paper in 2021 detailing some of the different innovations that clinicians in the school-based health centers moved to in order to alter their provision of healthcare. As I mentioned, about 12% of school-based health centers provided telehealth services prior to the pandemic, but more than 50% of them moved strictly to telehealth as a result of the pandemic. Some of the changes that the clinicians reported were, increases in the number of times that they would meet with the children or some of the at-risk children, moving some of the primary care provision to telehealth, doing mail-in STI kits, And then having primary care providers also provide some of the mental health interventions. So these are just some of the changes that occurred as a result of the pandemic. And I want to just touch on the digital divide. And we know that telehealth is a really helpful, impactful model for folks to access much needed health services. But there is a group of vulnerable children and adolescents who are increased risk or increased vulnerability for worsening mental health outcomes and subsequent academic outcomes that I mentioned before. So there are reports that 14% of children aged 6 to 17 years old lack high-speed internet, and 70% of those 3 to 18 years old lack access to a computer. These are some of the same children who live in low-income or rural areas and are at risk for increased mental health disparities and poor mental health outcomes. So I just wanted to touch on and mention this because I think it's important for us to remember as we think about how school mental health is going to be provided moving forward. I hope that in this talk, I've been able to shine light on some of the work our education colleagues have done and how we as mental health clinicians in the community and at UCLA can support and advocate for students. One silver lining from the pandemic is that there's been greater mobilization of resources for our most vulnerable children. The state of California has the Children and Youth Behavioral Initiative, which was announced in July of 2021, allocated $4 billion for the investment in school systems that support behavioral health for children, including the education system. I also want to highlight this recent article that is an important document. It shines light on how we as providers can advocate for children's basic needs, including education, internet, food, housing, as I mentioned, in our role, and that in working with youth, one thing to remember is it's important for us to ask about these factors or be aware of them and how these things may be playing a role in their mental health. And I guess a final takeaway I'd like to leave you all with is that's important for us as clinicians and as a department to continue to partner and collaborate with various stakeholders, including families, schools, and communities, so we can try to reduce some of the disproportionate gap in mental health care that existed pre-pandemic and only worsened as a result of the pandemic. So here are some of my references. I want to just thank a few folks, Dr. Kataoka, my supervisor who helped, who's really fostered some of my interest and helped me gain more leadership opportunities in a role of education. I also want to thank Elena Blum, who's been such a resource for me learning about education. I'll introduce Kim Griffin Espinoza in a moment. I also want to just thank my family, Michelle Alferez, who is in the LA Unified School District, who's also helped connect me to the school district and help me inspire my passion. I also have included my wife here, Adriana, who has supported me and my daughter as I prepare for this talk, and as she's supported me in my work in schools and things of that nature. So I want to introduce Kim Griffin Espinoza from the LA Unified School District. She's a licensed clinical social worker who has spent her career working in education and mental health settings, including LAUSD's school mental health program. She received her master's in social welfare, right here at UCLA, and has worked as a psychiatric social worker and in various leadership roles, and now holds the title of Administrative Coordinator in the LAUSD's Department of Student Health and Human Services. She's the recipient of awards for her work, including championing evidence-based practices within the community and improving mental health outcomes for students in LAUSD. We're lucky to have her here today to discuss her experience with school-based health centers and the future directions for the district as they adapt mental health care delivery for the post-pandemic era.
Thank you so much for that introduction. So yes, you covered many very salient points about how our children in our schools and our health centers were impacted by COVID-19. As mentioned, initially, there was a decrease in student attendance in schools. There was decrease in student engagement. And because of that, we had great difficulty communicating with our students and monitoring their mental health. And due to that, the number of referrals for students being referred for mental health services really went down. What we found, however, was that those students who rose to the level of our attention were those who were at extremely high risk. And so our providers really needed to provide extra support and services to those students and families. When schools reopened, things again changed. And what we found was that students were coming to school very, very anxious. They were very nervous about attending schools. They didn't, some of the students, really didn't know how to socialize with others anymore. And so, and our staff too were really struggling. There were a lot of student behavior problems in schools, and with all the changes of COVID requirements and testing and masks, and it's social distancing that really had an impact on our staff and our students. So almost immediately, referrals to our school-based health centers skyrocketed. So faster than ever before, referrals started pouring in, and we started servicing students as quickly as possible. One of the challenges was that our providers and community-based organizations had difficulty accessing students because they weren't necessarily allowed on the school sites because of the COVID-19 restrictions. And although we all offer telehealth services, one of the challenges for that is that we can't always provide that when students are in schools. And our parents in particular really struggled with our telehealth platforms. So we had to increase hours in our evenings, and we did a lot of training throughout the pandemic with parents to help them utilize our platforms. We did begin providing in-person services as soon as school reopened, and that was what we found the parents and the providers' preference for our students, and it was really helpful in servicing many of our families. I think, again, the number of students that we're servicing that are high risk is more than ever before. Our referrals are about 300 more than they were our last full year of in-person school. And we currently have more than 1,100 referrals than we did last school year. So what we're struggling with right now is so many students who need support, but limited ability to provide that support. There is a shortage of providers across the state who can provide services to our students. And so in order to address that, we've had to pivot. So when schools closed, we pivoted to telehealth. When schools reopened, we pivoted again. And now we are pivoting for the third time, because what we are finding is that although our goals in schools is to provide prevention services, there's so much need. Our staff was spending a lot of time on crisis response services. And so we have to pivot again to support our schools, to help them build their capacity so that every school employee can address student mental health and student wellness, and to support student mental health and student wellness, because there aren't enough providers where we can just focus on that top tier of students that need that really intensive work. So moving forward, we are building a youth ambassador program. We are teaching students how to advocate for themselves and for each other, and to provide education to each other regarding mental health. We have greatly increased our parent education programs. One nice thing about telehealth is we can access thousands of parents at a time by providing these programs in the evening over virtual platforms. We are also providing them in person though, because we know that some of our parents do not have access to telehealth platforms or prefer not to use them. We are also working on plans to increase school capacity, like I mentioned before, teaching our teachers, our teachers' aides, and all school staff how to respond, how to identify, and how to link students when necessary. We've also created a mental health hotline. So Monday through Friday, 8 to 4:30, we have someone available for anybody who needs to call and receive mental health consultation. We've increased mental health consultants from approximately 6, and we're aiming for 44. We're not quite there yet, but we're working on it. And we are, again, increasing our focus on prevention. Our attention was pulled away somewhat, but we realized that right now, instead of a triangle approach, we actually need a rectangle. So we need, we can't ignore the students at the top because there is so much need, but we have to build out our middle tier. We are providing more support through groups and middle tier activities. And we have to continue to build our prevention and universal tiers. We cannot let that fall apart where we're focusing on our top tiers, because then otherwise we create this cycle of focusing on intensive services. And finally, I know we don't have much time today, but we are working with many providers to increase mental health funding to schools, and to make sure that the short-term funding we receive through the federal government due to COVID does not go away, because our students are going to continue to need these services for many years to come.
Great, thank you, Kim. Really appreciate your partnership with us at UCLA, as well as all the work that you're doing for the hundreds of thousands of kids in LA Unified. We are open for a Q&A. You can type in any questions you have into the Q&A, and we can answer them in the next 6 minutes that we have left. But I wonder if you can, either one of you can kind of speak to kind of this huge system that you've both just talked about, and how to kind of coordinate it so that it's not like one program here or one program there. And, you know, you mentioned, you know, school-based health centers and their role. In LA Unified, we have wellness centers that are kind of even more comprehensive. And then Kim, you were also talking about the need to be, you know, more preventive, but how are you envisioning this all fitting together, all these pieces?
I guess I'll start. I think, you know, on my final slide, I think to fit the pieces together, I think it takes collaboration and partnership. It's listening to the various different stakeholders. I think, you know, connecting, having an avenue like this where we have, you know, providers and folks like Kim here to talk about from the education system and partnering with the district. I think that's an important piece. You know, it's such a large and vast system, not only LA Unified School District, but education system as a whole. And so it's important for us as, you know, here at least at UCLA and in our roles as mental health clinicians, to continue to build those relationships and partnerships in order to help bridge some of the divide or bridge some of the gaps that exist within the different programs, and communicate, I think, is a big key.
I would agree. One of the things that we've done in LAUSD is we have built collaboratives. So these are where our medical providers, our mental health providers, key staff at our schools, and our community-based organizations and our student ambassadors all come together on a monthly basis and talk about how things are going at our wellness centers, how the referral process is going, if there's any additional services that need to be provided, any additional partners that need to be brought on board. And that's been a really critical part of making sure that we are all working together and collaborating towards the same goal.
Mm-hmm. Yeah. And LA Unified is such a huge district. I think it's like 500,000 to 600,000 students, K through 12. And in partnering with you all in your evaluation of, you know, the vast amount of positions you're hiring now and kind of the impact of that on students, I've been struck by the thoughtfulness in terms of hiring, that you have this student equity needs index that you've used to hire, in which schools are kind of rated on this SENI index in terms of number of Black students who are low income in a particular school, number of rates of graduation, and other kind of factors that would potentially indicate that a school needs more mental health and health and human services supports at it. but like the district is hiring like over 1,000 new employees, both navigators to help families get into services for housing or food or mental health, as well as mental health providers like yourself, Kim. And so I guess what's the plan kind of moving forward? If you could speak a little bit to the district's like path to recovery, the kind of grand scheme to really address not just the overall need of services in the district, but especially the disparities and that gap that Ed was talking about.
Right, so you are correct. We did use a CINI index. So because we're doing so much hiring, and because so many schools have not had psychiatric social workers on our campuses, we use the CINI index in order to determine which schools received the social workers first as they were hired, and how much time they received from psychiatric social workers. So this way, the schools with the highest need would get their vacancies filled first, and they would get more positions allocated to them. So one thing we discovered this year is that there is a shortage of social workers throughout the state. And so we've had to adjust how we filled vacancies in schools as we've gone on, because the goal is really to have a psychiatric social worker in every single school, which is the first time that will ever happen in LAUSD. So that's one plan. I think with the path to recovery, we've learned that isn't sufficient just to have psychiatric social workers in every school, because what we know is when they are in schools, they do identify a lot of students in need. And so we need a way to make sure that we have the ability to provide those services, which is why we are expanding our ability in our clinics and wellness centers, not only to see individual and families, expanding our group options and our parent education options. And we are also expanding, again, our supports to our school staff so that we don't have as many kids who need to be referred, because many of these students do have issues that could be handled on the school site with supportive staff. So I hope I answered that question for you.
Yes, I mean, I think this is like the opportune time, and as Ed was mentioning earlier, there's such a highlighted need, and I think finally, policymakers are well aware of it and are funding from COVID funds federally as well as from the state into our schools, and really providing the necessary mental health and support services that hopefully will help decrease that disparity gap, as well as meet the needs of kids.
Yeah, we are expanding our school-based health centers as well. We have several that are under construction, and we had actually 3 that opened this school year. We have one that I'm aware of that will open hopefully in the fall. And so we're hoping that will help too, because those serve not just our students and families, but also the community. And so that's really critical.
Yes. Well, thank you both for wonderful presentations on this very important topic. And thank you everybody who attended, and we'll be back in 2 weeks. Thank you.
Thank you.